Hi, via Zoom during the corona crisis of 2021. I'm Frank Speidel, retired emergency physician and recovering hospital administrator, and welcome to The Doctor Is In. Now, again, we will discuss the COVID-19 pandemic, and as always, I advise I am neither an epidemiologist, public health official, nor an infectious disease specialist. Always defer for healthcare guidance to your primary physician, your local and state health departments, and the CDC. When I wrote the introduction to today's show, we had lost over 625,000 Americans to the pandemic. You'll see a slide which shows the mortality rates by nations and states. My first reporting on this tragic, devastating pandemic was in March of 2020. We shut down businesses and schools. We quarantined. Now, since December of 2020, we've had an effective vaccine. I invite your consideration of the CDC's report. You'll see the slide of a 7-day moving average of daily deaths. Now, I do not think COVID-19 will disappear, deep frozen like smallpox in a few Bio4 labs somewhere. I think SARS-CoV-2, like I've said before, like the other respiratory pathogens, will always be with us, infecting, reproducing, mutating, and subject to seasonal variations. The events of the past 20 months, the deaths of millions, the harm to all, deserves not just reflection, but ruthless examination. To me, this pandemic has revealed heroes and giants, as well as a menagerie of naked monarchs, carny barkers, crazed golems, howling inquisitors, and frightened children of all ages. The pandemic showed us titans still walk among us, the basic scientists doing bench research before the alarms went off. Individuals such as Penn's Dr. Drew Weissman and his brothers and sisters at the bench in basic science, providing decades of research on vaccines and immunology, groundwork in an mRNA vaccine a decade before the disease arrived. During this pandemic, other giants walked among us too, providing care at the bedside. They endured. They never quit. Nor were the heroes limited to healthcare. All those who showed up for work to interface with the public at supermarkets, at post offices, and a myriad of other places, the first responders and all those others who provided vital services, they deserve our expressed and loud gratitude. Now, sadly, we have been exposed to the king has no clothes syndrome. The list of naked monarchs is sadly led by public health agencies who are so vital to our communities in the time of pandemic. The performance of the CDC and the NIH leave much to ponder and examine. Greatest hits include aerosol fomite, outdoor transmission controversies, masking, travel recommendations, vaccination priorities. The origins of the SARS-CoV-2 virus are just starters. One can only hope that when their heads stop spinning, many people's noses are to the front. All this happened while we were watching this past June. 11-year-olds playing soccer outdoor while wearing face masks? Now, following the naked monarchs in the circus parade are the carny barkers. The media reporting on the pandemic. Scary grabs ratings. Accurate reporting does not. Consider the following headline, noting the variable increases of 26%, 36%, 70% of some variable not stated. A misleading technique of noting changes in a variable. Now, not to be outdone by CNBC, right? The satiric Babylon Bee reported similarly, noting 100% in the increase of cases soaring from 2 to 4. It's a true statistic. Point made and noted. Lest we forget, as of July 10th, the CDC reported the wondrous effect that long-researched vaccine had. Now, it's not all sunshine and lollipops. There's an upward trend in COVID admissions, and you'll see a slide showing that. And also a breakdown of mortality trends by ages reminds us this disease exponentially targets those with age, like myself. Now, for most of the media, lurid fear reporting gets rating. Accuracy is nothing but an impediment. Then stepping smartly into this circus parade are the crazed columns seeking the ring of power. The control to tell others what to do has always been seductive. This time is no different as faceless bureaucrats solemnly intone their latest pronouncement. Let's see, is it 3 feet or 6 feet for separation? And what does the American Federation of Teachers Union want? The great Oz has spoken, and he's not hiding behind the curtain anymore. No, he's clamoring for the TV camera. But don't ask him a question. He doesn't like to answer questions. Sweeping this in the sweep position for this procession are the howling inquisitors, the fact checkers, the censors. In the shrillest traditions of Thomas de Torquemada and Robespierre, this tribunal of the uneducated assures correctness of thought through purging discussions invoking settled science, lest the masses be corrupted with disinformation. And everyone knows that the virus jumps species, right? And those who express concerns overlapping, well, they were blasphemers and they need to be silenced. My thoughts? E por si muovi, still it moves, as that 16th century Italian noted as he recanted his misinformation to the Inquisition. I believe there's a reality, and it's not cant. Our glory is not that we do not make mistakes. Our glory is that our knowledge is perfect. No, our glory is that we question. One of the recurring messages of this show is the robust questioning of truths. There is no settled science. We progress, we grow through questioning, not censoring. This is primal, embedded deep in our culture from the 18th century Scott David Hume, who reminded us that truth springs from arguments amongst friends, to the 20th century Californian Carl Sagan's admonition. The sacred truth of science is there are no sacred truths. Another recurring message of your host is to paraphrase Carl Sagan. Extraordinary actions require extraordinary evidence. Extraordinary actions, such as locking down society, devastating business, shuttering schools, masking soccer players, and planting fear thick through society. These actions require extraordinary evidence, not hunches, not I think that's not the consensus of experts. Now, one of the fun things I get to do in this show is I get to meet really, really smart people, such as our guest today. To bring clarity to these times we are given, I'm honored to have as our guest Professor Monica Gandhi. Dr. Gandhi is Professor of Medicine and Associate Division Chief of the Division of HIV, Infectious Disease, and Global Medicine at UCSF. She also serves as the Director of UCSF Center for AIDS Research. Now, besides these shining academic achievements, Dr. Gandhi writes extremely well. Orwell noted that writing well went with clear thinking. Sure is true here with Dr. Gandhi. In addition, Dr. Gandhi has the wonderful, aware, sensitive values that mark the giants in medicine. Dr. Gandhi, welcome to The Doctor Is In. And what did I get wrong?
You got everything right, actually. I think a lot of what you said was extremely wise, but also specifically how we have to change guidelines with updated data. We have to change, especially in the setting of this prolonged pandemic, what we did with schools and children. And so I really appreciated your initial commentary.
Well, I appreciated I used to read your articles and I go, this is incredible. Yes, thank you. Thank you. But it's not an article written by, you don't make your living writing articles. You make your living taking care of very ill people with infectious diseases. And trust me, if I had my ways tomorrow, you'd be heading the CDC.
Thank you.
It's true. I sense that you're aware of trade-offs when we make decisions. Could you comment on that? Is there a risk-reward analysis we should know about?
Yes. I mean, looking at the trajectory of the pandemic in the United States, for example, everyone had to shut down in March of 2020. We had no idea how it was spread. We had no idea if it was asymptomatic transmission, which there was. We had no idea if fomites would spread at surfaces. All of that had to be done at the very beginning. And then we got data. And what data did we get? We got data that this was a respiratory virus, that it spread through the respiratory secretions, that there are absolute mitigation procedures we can use, masks, distancing, which we can talk about, and ventilation most of all, to mitigate the spread of the virus. And that is when we needed to think about ways to keep people safe, but still not create these prolonged closures of essential needs. What was an essential need? schools. What we saw in this country, which by the way, as you know, we did not prioritize school openings like the UK and Europe did. They just decided that children needed learning. And because we didn't prioritize school openings in that way, we are now seeing the mental health effects of prolonged school closures, eating disorders, learning loss. 3 million children at least checked out last year. And those kind of losses can really last into the lifetime. And so I think my approach to this pandemic had been more around the approach that I would think about with HIV. HIV never said, well, maybe at the very beginning. At the very beginning, HIV may have said, stay away from each other. That's the only way to stop an epidemic. Instead, what HIV said is, we understand human need. We understand that people want to be intimate, people want to be together. Let's tell you how to stay safe. Let me tell you about harm reduction. Harm reduction means you want to reduce infections, but you take the real world conditions of human beings into account when you do that. And harm reduction somehow was not applied to SARS-CoV-2 mitigation after we figured out what it took to mitigate.
I could not agree with you more. I was at the bedside when HIV started, and I remembered there was an editorial in the Annals of Internal Medicine. I will not mention his name, but he is very, very prominent. And he speculated there, and this was in 1983. He speculated that it may be transmitted by it may be subject to casual transmission. When you're trying to staff an emergency department, when that comes out, and that was picked up on the news, I had people refusing to work in the emergency department. I had to argue with one board who said, we just won't see patients that have that disease. You can't,
it's imperative to not see those type of statements unless you have backing for them.
Yes.
Right.
Thank you.
Right. And you know, one thing I've thought about, again, going back to that connection, we used to, in HIV, let's get a little graphic, but oral sex was not risky, and you know, different types of sex were. And so we didn't have to apply the same rule across the bar. And it's the same thing here, right? Like, we don't have to apply a blanket approach. We say, okay, what are the risky activities? What can create spread of the respiratory virus? Let's mitigate there. If this is not risky, being outside, for example, with SARS-CoV-2, because we learned quite early on that the virus hates the outside air, it dissipates very effectively. There was a University of Canterbury scoping review performed in September of 2020 that really, frankly said, encourage people to go outside. That's what, because you can't tell people not to be around each other. It's human nature. Tell people to go outside, but we didn't apply those.
There's a wonderful early on, and I think it's actually February or March of 2020, a study out of China that looked at like 7,400.
Yes.
They documented very well. And it was something like 1 or 2 cases were outdoors, and they weren't even certain about that.
That's exactly right. That was the best contact tracing study. You're right. It was 7,400 infections, and a handful were linked to outside, and it may have been that they were inside, you know, at some point.
I know.
That was the one that really showed me that it's very hard to get SARS-CoV-2 outside. And we could have pushed people outside much more, schools outside. We could have done a lot more outside during the pandemic.
Just to get kids. You were mentioning, I believe that it is fracturing young people growing up who need the socialization. I'm concerned that we have devastated from a mental health stability, a whole generation. And it's not my view of the world, which is obviously a single view. The people that have the least resources to cope are the ones that have been most abused by this. You're going to learn at a screen. Not everyone has internet accessibility.
I think that is such a good point, because one thing that I wrote a BMJ article the other day, just with a couple of other researchers, about how our restrictions and the pandemic didn't serve the poor, right? So actually what happened is the pandemic, which is the history of infectious diseases, they always disparately affect poor and vulnerable populations, which if we haven't figured that out yet, we should have. And so providing resources to people to be able to stay home, we could have done that in a different way. But instead, the pandemic response also was profoundly painful and more difficult for poor and vulnerable populations. Because if you were doing Zoom in a screen, like you just said, your parents are essential workers, they had to go to work, where you're alone at a very young age, alone in a room on a screen, that's not the way to learn. And we just could have done it differently. I mean, the important reason about your show actually and what you're doing right now is even if we can't do anything in what we did in the past, moving forward, we can change.
Yes.
If we learn from what you're talking about.
Yes, we make mistakes. The important thing is that we question what we've done and that we grow from it.
We have to question, yes.
So speaking about questioning, this is a tough segue, but I'm going to force it. I tend to be a vaccine advocate, and I've been pushing people to get vaccinated. I know right now it's an emergency use authorization. I understand that, but please, it works. There's good big numbers.
There is.
So then someone approaches me and says, well, you obviously don't believe the CDC because they're reporting every week thousands of people are dying. It's in their VAERS study. Well, what is VAERS? What am I
really want to explain that because unfortunately, this is the worst way to collect adverse event data. And so let me explain this. So VAERS stands for Vaccine Adverse Effects Reporting System. And what it means is that absolutely anyone can submit a report to the CDC that says something happened around the time of a medication or a vaccine, in this case, the vaccinations that we've had in this country. And they have to take that report and put that in a report form, and it can look like people are dying. Now, this is the biggest mass vaccination program in history. We have given out 161 million Americans are fully vaccinated. Like you just said, there are 3.5 billion doses given out worldwide. And when you have a massive campaign of something that's happening, it's almost like the sun is shining. Like something is happening, like mass vaccination, the sun shining, and there will be other events that happen too. There will be deaths, unfortunately, of people naturally from other reasons. There will be things that are bad that are happening that are unrelated to the vaccine. But all of those can be reported and submitted to the VAERS system. And so it can look very much like these, 1,000 deaths that because there are deaths, life starts and then we die. I mean, there are deaths occurring all the time in any country, in any place. You can put in that it's linked to the vaccine when it's not. And unfortunately, that is what you are confronting when people say to you, look how dangerous these vaccines are. You are absolutely right. They are safe and effective. What's the best way to gather adverse event data is to take large cohorts of individuals and report on adverse events. And that has been done. The Mayo Clinic healthcare system put out a really good report about the very low rate of adverse events with vaccines. There is a different way to show adverse events, which is cohort large population data. That's what we should use instead of VAERS. Interesting topic,
leads. One of the things I was sad about is that I haven't seen a lot of good prevalence studies so far. When this first occurred, I was very, very curious as to, for every case we saw, how many people out there were disease-free right now, but had been exposed and had become infected. I was disappointed we didn't see more coming out of public health than that there were not more good prevalence studies. Were you aware of any at the time?
I completely agree with you that is disappointing because what happened is the CDC would collect seroprevalence data, but it was usually in blood donors, which actually can be a more skewed population because, for example, we were thinking that we needed to give convalescent plasma at one point. So people would be actually coming in to give plasma to treat COVID. So you're more likely to have had COVID. And then there's other skewing of people want to know their antibody status, so they go and give blood. So those aren't the greatest populations to study seroprevalence. I will say that though the CDC didn't do this, California did do a general population seroprevalence study that was quite good right after the winter surge. And it was very sad to see that 38% of Californians had been exposed to coronavirus. And this is, of course, before we had rolled out the vaccine in the general population. Healthcare workers were getting it. So I think that was a study to show that maybe a third of this country had been exposed and had antibodies. And that natural immunity, I mean, this is a whole other topic, but we've denied natural immunity to a certain extent, and we can't deny natural immunity. I mean, if we didn't have natural immunity, we'd all be, we'd all die by the time we were 1. Like, we all have immune systems. So I'm sorry, but like, natural immunity does exist to viruses.
We are meant to swim in a sea of pathogens. We evolved to do that. We forget that there are other things that kill people, probably about 35,000 Americans will die in motor vehicle accidents. 4,000 kids will drown in swimming pools. This is tragedy.
Risk versus benefit, yeah.
The trade-offs, the important. Yeah. I used to be amazed. I used to be amazed when I was in the EDC. Young healthy people come in and die of pneumococcal pneumonia.
Yes.
This is a safe place, and we have to live our lives reasonably and smartly, being aware of the trade-offs. I was stunned by the American Academy of Pediatrics saying that we have to mask from 2 to 12 because we don't have a vaccine available, both indoors and out. Any thoughts about that?
Yes, so a lot of that didn't make sense to me either. So there was 2 things. Number one, the outside question we've already just addressed. And really, I mean, there are pictures from the 1918 pandemic of children being outside with their feet up on cinder blocks to warm them in Boston because they didn't close schools in the 1918 pandemic. Why? Because you didn't have screens, you didn't have Zoom, you didn't have computers. And so people recognized the importance of in-person learning and they took it outside. And so outside learning and outside time and children being outside, is so safe. And I don't understand why the American Academy of Pediatrics wouldn't take into account the data that we just discussed about how the virus just does not like the outside air. It dissipates very quickly. And so it's safe to be outside unmasked. In terms of inside, this is a very interesting question that you bring up. So, I have been pushing specifically for metrics because the reason I say metrics is I don't think anyone thinks that children should be masked ongoing forever in school because you just mentioned what you said about the immune system. We actually have to be exposed to mild pathogens. We have to be. If we don't get immune diversity and we don't get microbiome diversity. And actually, that makes us more prey to autoimmune diseases, allergies, and cancers. So it is important for us to coexist with mild pathogens someday. I know it's not the best time to say it in the middle of COVID-19, or as we're ending COVID-19, but there will be a time where we need to accept that we have mild pathogens and that actually increases our immune diversity. It's why we're worried the flu season this year will be difficult and very hard because people have not been exposed to pathogens. Now, going back to children inside schools, we have been pushing for this approach that yes, parents and teachers, some parents not, but many parents are going to feel safer with their children in masks in schools. And the reason we use this metric-based approach is saying, let's come up with a time where the rates of transmission are so low in the community that children are not protected by their vaccination status because frankly, they don't have a vaccine yet. They're protected by 2 things. One is that they are inherently much less at risk for severe disease. That is an undisputed fact. And the second is that if you have low rates of community transmission, they can't even get it to spread it to a grandparent, for example. So we have been pushing for a metric of less than 5 over 100,000 hospitalizations in a region. Right now, there are places in the United States that are not at that with the Delta variant. There are places that are, like Vermont, which have high rates of adult vaccination. And at that point, that's when the masks come off for children inside, because that allows to me, metric-based messaging allows endpoints, it allows off-ramps, but it also, when we're trying to get children back into school, there are certainly teachers who have expressed concern, and you mentioned the American Teachers Federation, and you mentioned how difficult it was this year. There are teachers who are still very worried about it, and this, I think, lets us start out with kind of mitigation procedures that make some people comfortable, and then we have a metric-based approach when people who want their children masked can have their children masked, people who don't want their children masked. So it's recommended but not mandated. So that's my approach to the masking in schools. And I think, to me, it makes sense and it pleases a lot of people and there's compromise, but that's not the approach AAP's taken, nor is CDC, interestingly, because CDC said yesterday metric-based approach for masking, meaning if there are high rates of community transmission, even if you're vaccinated, we want you to mask inside because there's more circulating virus and you could get a more mild breakthrough infection. That's what they said yesterday. That always made sense to me, to have a community transmission or a hospital metric to when masks come off. But they didn't say it for kids. They didn't say that they would change. And what people in Vermont would say is, let's see, we have 80% vaccination rate. We have very low community transmission. We're not having those hospitalizations. We did, what other states didn't do in terms of uptake the vaccine. And we don't understand the ongoing restrictions. But they didn't put ongoing restrictions for adults, just for children.
Do you ever feel like you should have a degree in political science too? The players that have their fingers in making this stew is fascinating.
Yeah.
No matter what you choose, no matter what course someone like you recommends, at some point in time, some child is going to have a multi-system inflammatory syndrome and is going to have a bad outcome. It may not have anything to do with masking or being in school or playing soccer outdoors. It's going to happen. And you know that people will be trying to point fingers, and the world's not perfect. The best we can do is make reasoned, science-based assessments.
Reasoned, science-based assessments. I really like that comment because I think we have lost our perspective on risk versus benefit analyses at this point. Like you just said, things do happen that are bad. And what we have to do is mitigate risk as much as possible, but also look at the bad impacts of school closures, look at the negative impacts of mental health difficulties, look at the negative impacts of learning loss. We have to put all of this in a benefit analysis and put it together when we make decisions.
Thank you, Professor. We should cast that in bronze. Masking. Emergency physician, that was my career, and it's basically very primitive. It's get an airway, get a line, get somebody else. It's not very sophisticated. So when I was asked to do a show on this back in February of 2020, I did a deep dive. And one of the things that amazed me was aerosol transmission as opposed to droplet fomite transmission. And the thing that first struck me about that was, I remember, I think it was 94, there was controversy about TB in an aerosol transmission too. And one of the things about that was, I think that there was some controversy because a mask is not a mask is not a mask.
Right.
And an N95 mask worn appropriately, a respirator, is not a pleasant way to spend a day. I bet you've done that too, I know. And yet at the same time, we have these little masks that people feel that we're helping out with. Would you comment? And I got to wrap up in a second, but I'd like to hear your comment about that.
Yes. So I think this is a great point. So let's just admit it that essentially this is more of an aerosol than droplet, but I actually don't like this word aerosolized and droplet. And I'm going to write a paper after this pandemic is over with other smart people in the field that says, let's actually think about what mitigates a virus. So for example, what masks work? What masks are effective for this type of virus? And so when you look at the SARS-CoV-2, you're absolutely right. It's active. We have to say it. It's an N95 or something like a more fit and filtered mask, one that fits tightly around the face, maybe even a double mask with the cloth that puts the surgical on top of it, or two cloth layers with a filter inside. And I wrote a paper with Lindsay Marr talking about these different masks and how these were better masks, and these were the masks that we should have given to our essential workers, again, who were inside and had to work in the context of SARS-CoV-2. Because by giving masks that don't block in that same effective way, we may have put this idea that everyone has to wear a mask, but we weren't scientifically about what masks work for this type of virus. And so on the other hand, outside, I don't think masks are needed at all. And we're still, and you just said that comment about AAP and masking children outdoors. And you just had to think in a scientific way about masking. You can't just put these blanket recommendations in place without actually thinking about why you're doing it and what it takes and what masks are required and the aerosol droplet spread. And you're right, you're just pointing out to me, and it's just really hitting me right now that we put a lot of blanket statements in. They were just blanket, that's the word, isn't it? We put a lot of blanket statements that didn't fundamentally were chiseled and tailored and recommended to the situation. And that's what I'm going to go back to end this, is that there were ways to tailor and chisel our lockdown approaches, our recommendations, giving resources instead of fundamentally keeping everyone away from each other, saying that everyone was at risk for COVID, which wasn't true. It was more people who were in the workforce and essential workers. It was more the vulnerable. And we just have to do this differently next time, because I think we caused a lot of difficulty and we caused a lot of fear.
Professor Gandhi, I cannot thank you enough. You, lady, are the one to lead us out of this morass.
You are amazing. Thank you. Thank you for having me.
Oh, thank you, Dr. Gandhi. And now for a perspective. This past year, in July, we lost the general manager of mainline TV, Mr. Vince Celli. To say that he was general manager of mainline TV is akin to saying the Thames is a river. Vince was so much more than that. I was honored to work with Vince. He taught me much and he helped me to grow. The first time I met Vince, I was struck by his competence, but more striking was his kindness. He was a man open and tolerant. We need that nowadays. Interested and interesting. Sadly, we are awash in the shabby. Vince was the antidote to the shabby. We are all diminished by his passing. Peace, Vince, and peace for your great family. And thanks for watching The Doctor Is In, and stay safe.